He's a graduate of McGill Medical School, and he did an internship and residency at the Royal Victoria Hospital in Montreal. And after that, he hied himself off to that mecca of all good physician training, known as Boston. And there he went to Mass General Hospital and to Brigham Women's Hospital, and then to the Dana-Farber Cancer Institute. He's the author of over 100 publications, mainly in the area of breast cancer, but other areas of oncology too. And he is a reviewer for various medical journals and has won various research grants. And I'm absolutely thrilled that he is both with us on the committee and kicking off this lecture series for us. So,
here we go. Okay. So thank you for that introduction, and thank you for showing up. Hopefully you'll hear a few things that are helpful, and hopefully there'll be time if people have questions to partake as well. So the genesis of this title, Only in America No One Dies, came out of some discussions with friends and interactions with certain patients. As you heard, I'm a medical oncologist, hematologist, and spend a lot of time, most of my time taking care of patients with cancer with an interest in breast cancer. But it's really with a discussion of a very good friend of mine who's about 87 years old, and he's PhD, very well educated. And he told me the story about a friend of his that had cancer, and the oncologist kept on treating him continuously over and over, changing different regimens, till the patient said to his oncologist, "Could you just please stop?" And I think that was very good for me to hear, because sometimes we fight the battle, but sometimes don't admit that we're going to lose the war or are losing the war, and fortunately the patient is the casualty of our fighting. So part of it was, and I think all of us, but those of us providing care have to remind ourselves that it's good to fight, but sometimes the fight is over, and you need to recognize that. The other part of it was taking care of some patients that, their expectations were just too unrealistic, and they had essentially a fatal disease, and they just could not migrate to a point where quality of life was the goal. And there was a really angst that I felt, and I can't shake them to say, don't you get it? Everyone, you're born and you die. And there's this, and since I'm a Canadian, we Canadians don't think that way. I blame Americans because, only in America no one dies, because this seems to be, at least on a superficial way, an unrealistic, unrealistic wish, and also makes for maybe a provocative title. Because the real title is a roadmap in dealing with life-threatening disease. But I'm going to, why we might feel optimistic about fighting serious illnesses will be demonstrated in the next slide, which I think we have the slide changer. So, I think all of us have seen enormous metamorphosis in medicine in our lifetime. I'm reading The Team of Rivals by Goodwin back in the times of the early 1800s, and it's amazing if you read that book how people just died of nothing. Mrs. Smith, who was 30, dies of pregnancy, related complications. Little boy Todd dies of an infection that would now be treated. So death was very common. Today, many conditions are dealt with successfully and avert death, at least for a while. So, and this has really come out from a better understanding of biology and better management of the range of diseases that we see. So the next slide. So the biology part. Now remember Biology 100, or maybe you don't want to remember that. So we have a daughter who just went through medical school, and one of the unfortunate things about medical school training, it's still laborious and takes forever, but they just add on more and more information. I graduated from medical school about 40 years ago, and I had to learn X, and today medical students have to learn X plus Y because the amount of information keeps on exploding. But with that has led to better treatments. So the biology part, if you see the next slide, So these two guys, Crick and Watson, so 1953, 60 years ago, discovered the secret of life. I mean, if you remember biology, there was something called spontaneous generation. You know, out in the corner, life appeared. And so DNA, for many of you, was not a concept, maybe until you were young people. I was a young person. So these two guys, next slide, discovered the DNA helix and won a Nobel Prize. But that opened the door to, next slide, that the appreciation of the chromosomes we have, and the DNA makes up those chromosomes. The DNA is made up, is responsible for the genes, which lead to the proteins that we make. And what was really amazing, now about 10 years ago, the human genome was mapped, which cost millions and millions of dollars to achieve. But today, your genome can be discovered, mapped, for about $2,000. And the future, a lot of us hope, may not translate to a success for every battle that we need to fight, but we will have a genomic, your genome, your DNA will be understood. And now the issue is, it's a little bit of the technology ahead of what we can do with it. We'll find out a lot about you or ourselves. I'm not sure we'll be able to solve everything we find out. But it is amazing that that has happened now. And it really has transformed our understanding. So this slide is, one view is the sort of the optimistic, positive view that this is going to enlighten us and give us better opportunities to find better treatments, hopefully cures. And then on the right side, a little bit more pessimistic, or it says, God, the human genome code has been unraveled, and then God is saying, damn hackers, now I have to change the password. If he can remember the password, which I find is a problem I have, but use the same one is my recommendation. Anyway, but I think it's going to be exciting. We were just having a casual conversation before this started about, do you really want to know your genome? And I grew up with knowledge is power, during the 60s. Not sure that's always true. But probably at the end of the day, it's better to know than not to know. And as we find better ways to treat certain diseases, maybe we can treat them better. So that has been the amazing part that's really occurred in our lifetime, and the opportunity for more understanding and better treatments really does exist. The other piece is therapeutics. And the next slide shows this Scottish physician, Sir Alexander Fleming. So 1928, it was probably a while ago, right? And he made an accidental discovery of penicillin. Some mold that was growing, and he was about ready to throw it out and realized it was penicillin. And then, for those of you who can remember World War II, I remember reading about it. People would die of easy infections, and then penicillin was, at that time, was available and being used extensively. But now, from that discovery in 1928, there are now over 160 antibiotics. And now the concern is maybe we used them too liberally, and that causes some problems. The next slide just shows how this is going. And we now have about 6,000 different therapeutics available. So lots of pills and capsules. And yes, some of you may be taking some of those as well. But so lots of opportunities to be able to deal with disease. By the way, this should be an advertisement for our memory key that you can have. Now, we're not quite figuring out how we're going to unfold this, but the idea is when you go to the doctor and you don't know what you're taking, and yellow and blue doesn't count, and when you go to the emergency room and you don't know what's taking, that's actually kind of an important problem to resolve. Some people put it in their wallet or in their purse, but we now have a memory stick that theoretically the physician could put in their computer and would spit out some information about you. We have some HIPAA experts here where we think it's HIPAA compliant. You signed something saying it was okay. But anyway, that is, so there are a lot of medications, and it really is a challenge, but it also leads to better opportunities. Next slide. Devices are also new. And there are many examples, but the example I find most impressive is demonstrated on the next slide. This is, the top is, this is an EKG, and this is a normal sinus rhythm. On top, that's the way our heart is going. And then on the bottom is ventricular fibrillation. So some of you may not know, but this was not appreciated until maybe 5 or 6 decades ago when people's hearts stopped. It was like, okay, I'm not sure I can do anything about it because we didn't have EKGs. But once it was discovered that the heart was fibrillating, then people actually said, well, it's an electrical organ. Why don't we reshock it and put it back into sinus? And that's what we did, and that's what you read about. You know, that's what the medical technicians do if they find someone who's hard to stop. That's why when you go to the airport, you find those defibrillators. Next slide. But what's really, I think, mind-blowing to think, so people, we can recognize there's certain people at risk for ventricular fibrillation, certain criteria, and some of you in the room may have one of these. This is a defibrillator. Okay, that's kind of cool, but where is it? It's implantable, and you can see in the chest x-ray on the next slide, there it is. So this is in someone's body, and if they go into a ventricular fibrillation, this machine will detect it and shock the heart. So if you're in a theater and someone says, "Whoa!" It may not be what's on the screen, it may be they got a little shock. Okay, I mean, can you think of that? I mean, some of us before, you know, around the time we were born, we were young kids, people would die of this. They weren't sure what it was. It was ventricular fibrillation. They figured it out. Someone had the chutzpah to shock the first person out. That took a fair amount of bravery because they had no idea what they were doing, really. And it worked, and then it became standard. You know, but now you can have it in your body. We're not talking about pacemakers. That's another cool thing. But this is a defibrillator. So it's available, and Medicare is still paying for it as long as you meet the criteria. And I don't think that's going to change next year. Don't worry. Still be there. So you have these devices. So that's pretty cool. Next slide. And then the other issue, which has dramatically changed, is diagnostics. You probably remember, you know, 50, 60 years ago, the doctors had x-rays, chest x-ray. It was not very sophisticated until these guys showed up. Next slide. Not the guys on the left, but you remember those guys? It was like 1963 Ed Sullivan Show, the Beatles. Remember that? Okay, 63 has become a big year, especially tomorrow. 50 years ago, but these guys showed up. But the people who financed them, EMI, also financed this other thing called CAT scans, CT scans. And today, they're routine. I mean, it's to the point that if you come into the hospital with belly pain, and you used to get an examination, they would check a couple of things like blood work. Now you get a CT scan, and then they talk to you. You know, an indication for getting a history from the patient is a negative CT scan. I mean, it's just done automatically, probably excessively, and there is a bit of pushback about all the radiation we get exposed to with all these scans we do. But you know, this is through the chest. That middle thing is not a tumor; it's called a heart, and you can see the lung on the right and left. But they really provide an enormous amount of information. Next slide. So this is a pretty cool thing. This is a PET scan. So a CT scan looks at the anatomy. This is really sharp. This is looking at the physiology of tissue. What you do is get a little bit of radioactive glucose. You get an injection, and it goes to tissues. And depending on the uptake, you can see things. Now, the uptake is mostly in the heart, so that's normal. And this person keeps on turning around. But you can look at it, and it's added to our understanding. So when we have difficult cases where a CT scan can't solve the problem, we often will order a PET scan. So this is another piece. So the armamentarium, in terms of diagnostic tools, is increasing significantly. Next slide. This is the MRI. This is another tool. This does not require any radiation, so that's an attractive piece. If you ever had an MRI, it's pretty uncomfortable. It's a good reason to have a couple of drinks or some Ativan because it's very enclosed and it's very noisy, but it provides enormous amount of information. So this is another cool tool. And next slide, in one area that's found its real use is in breast cancer detection. Women who have a higher risk for developing breast cancer, genetic predisposition, MRIs of the breast are used and are more sensitive than mammography. So these are also, so what I'm trying to build is this idea that we understand biology better. We have all these things we can take for different diseases. We have devices that keep people alive that we didn't have before. And that was just the tip of the iceberg. And then we have these image studies. Next slide. So, you know, earlier diagnostics, better therapeutics. If you catch it early, it's a chance for cure. Or as the surgeons say, if you can cut it out, it's a chance for cure. They like to cut, right? So next slide. So I'm going to use a simple example of breast cancer, A, because it's something I do every day, and B, it's something that people know a bit about. So in breast cancer, we expect better outcomes because of earlier diagnostics, because people are now having mammograms and when it's appropriate MRIs, and better therapeutics. Next slide. I'm going to dive here to an area you have not been, and maybe you don't want to go. And this is risky because I'm going to bring in a few pieces that are not familiar to you probably. So take a step back. So breast cancer is related to estrogen. That's why 99% of patients are women, because they make more estrogen. And that's mediated by receptors, which the estrogen stimulate, estrogen receptors. Now, here's the part that's going to take a leap. There's also another receptor called HER2, H-E-R. There is no HIM2. There's a HER1 through 4, stands for human, we got that one. Epidermal, sounds like skin, but any epithelial tissue, receptor. So it's HER2, and there are 4 of them. So next slide, and this is, so it's going to be pushy here. This blue thing is a cell membrane, and this is the HER2 protein. And what's kind of cool about it, it's sort of outside the cell. It's a receptor saying, come and say hello. And then there's a part of it within the cell. So that's out there. For a long time, when we saw someone with breast cancer and they were HER2 positive, we'd say, shucks, that means you have a more aggressive disease. But what was really amazing with all this science that you heard about, next slide, people were able, and this is just a slide that you can pass on, it just shows it's a complicated protein that interacts with a lot of things within the cell. And that's why you didn't like biology. So next slide. This is another, let me take a moment. This is pretty cool. Just to show, I mean, so we know we have, so many chromosomes, and we know these chromosomes have genes, right? And we know that we get a gene from mom and a gene from dad. So if the HER2 protein comes from the HER2 gene, we must have 2 genes in every cell, one from mom, one from dad. And that's usually the case. In certain tumors, because tumors are products of mutations, because the DNA is not right and the DNA gets messed up, you end up with more genes for HER2. Now, this is the cool part. This might be a bit test with the lights, but you see those round things, those are called, they're tumor cells, but they're cells. And you can see there are a lot of red spots, right? We agree? And you see occasional green spots. You see a little green? So the green is the control, and the hard part to see, in the normal cell there are 2 greens and 2 reds. Trust me, but that's normal. In the tumor cells you can see a lot more red spots. Those red spots, those individual spots, are genes, not chromosomes, genes. That's amazing. So this tumor has much more red spots, which means that there's much more HER2, which means that HER2 is a player in the function of that cell. And what's cool is the next slide, I believe, shows that we were able to develop, scientists, not me, I helped develop the drug in terms of a therapeutic. It was a great ride, but this is an antibody. We make antibodies to bacteria, that's how we fight infections. So this is an antibody to the HER2 protein. And it's an antibody that you will tolerate, humanized antibody. So we give this drug, trastuzumab. The names come up because they want you to remember the trade name, which is Herceptin. A lot easier to say than trastuzumab. But that's a generic name. And that binds to the HER2 receptor, and it immobilizes the receptor, so it can't be used. We now see some of our best outcomes in patients with this disease that had a really terrible prognosis because of this new biology. So it's pretty cute and pretty neat, and an example of kind of things we can do. Next slide. That's all I think I'm doing about biology. I'm going to leave that soon. So I've tried to create a bit of a framework for maybe we should do much better with a disease when we're diagnosed. And maybe we can even think of cure. I mean, other diseases get cured. Why not mine? So, when we're diagnosed with a seriously, potentially fatal disease, why can't we beat it? We have all these medical advances and diagnosis and therapies. As we know, we're a can-do nation, and yes, we are stubborn. So to demonstrate that a little bit, next slide. Remember this? This is during World War II, when women were given the opportunity to take responsibility until the guys came back after the war. But this is, is it Rosie? Thank you. And we can do it. And this is a quote of one of my colleagues, Lowell Schnepper, that it's hard to believe that a disease that can get the better of us with such great technologies available. So this is the environment that we're working in. And if you get a new diagnosis of something, you have this environment where we're succeeding. Why not succeed with my situation? So that's part of it. Next slide. I used to use this slide, I still do it. Lance Armstrong's brand has suffered in the last 2 or 3 years. This is not a EPO erythropoietin red cell commercial or what happens in the bike athletic world. But what's amazing about his story is Lance Armstrong, before he became who he is, had metastatic testicular cancer with brain involvement. Now, just about any metastatic cancer with brain involvement is not curable. It's just not going to happen. I mean, you can fight it for a long time, but it's unlikely, except if it's testicular cancer. And he was lucky because a guy named Larry Einhorn was studying testicular cancer and realized by adding one more drug that changed the disease dramatically. So now people with stage 4 testicular cancer potentially can be cured. And then Armstrong not only was cured, but then went on to do a lot of biking. So, if he can do it, why can't I do it? Next slide. There's a little bit of poetry here by Dylan Thomas. Do not go gentle into the good night, rage, rage against dying in the light. So it's we don't want to go. And, can't we figure it out? And it's even interesting, Christopher Higgins, who wasn't too sure about life after death, but when he had head and neck cancer, he went around looking for, and he actually did have his tumor tested with genomic analysis, but he had a bad cancer and he finally succumbed. But he did have some rage, even before he was diagnosed. Next slide. So to give you the framework and not get you completely depressed, but this is our world, my world as an oncologist, is there's nearly about 1.5 million people diagnosed with cancer each year. As you notice, since we have a mature group here, as you get older, the chance of it catching up with you is greater. The sobering number is that there's still over 500,000 deaths, and when you look at gender, 1 in 2 men will develop cancer and 1 in 3 women will develop cancer. So this is just one of the things that can catch up to you. If I was a cardiologist, I'd talk to you about heart disease, and people can die from heart disease. Next slide. So here's the part that I hope is helpful, and this is the one where we're going to take a deep dive and really become practical, which is how to deal with this. So we're going to start off with people like ourselves, reasonably intelligent, have reasonable resources, and we just went to our doctor and we got news we did not want to hear. So how do we handle that? And I won't do the first hour, we won't discuss, because that's probably the first hour after you hear that is not pleasant. But how to deal with it once you get beyond that. How to deal with a life-threatening disease. Next slide. So what you're going to hear is really my impressions from doing this for about 30 plus years and talking to lots and lots of people and seeing a lot of people and how they have done it. And this is my takeaway. And frankly, when my turn comes, this is the roadmap I hope to choose. So when you get a diagnosis, the chances are you probably have a correct diagnosis. But you really do need to understand it. So we've been having discussions in our health committee how it's really important that you take some ownership over what's happened to you. Medicine, when we were growing up, the doctor was God and the patient was someone below. And it was a unidirectional flow of information. You were told, and you pretty much did it. It's like having children today, I guess. It's a much more of a two-way street. So it is when you see your doctor, you're not a child anymore. So you need to ask about it. And we have now Dr. Google that we can always consult, which is now physicians who really get upset by that. I have to tell you, my impression is they don't get it, because when something happens to us, we go seek information. So if something happens to you, why not seek information? Now, not everything on the internet you should read, but most of us can figure that out. So you should understand the diagnosis. And if you have a physician who struggles with your countless questions, he or she doesn't get it. They're not practicing in the 21st century. You need to slow down the process so you understand where you are. And confirm and verify. If there are any issues, it's okay to get another opinion or if in terms of cancer, most of the time, 95% of the time when it comes to a cancer diagnosis, the pathologists have it right. But, I have patients who want to look at the path report. Well, I want to look at their scan results, and that's all, that's, I think, all very appropriate. The other thing is, who's probably the most interested person in you doing well? You are, okay? And so, I don't know if you want to do it with a file or want to use some electronic support, but begin to track your journey. I was talking to an Indian friend from India, and he said many years ago, it's interesting, it's a healthcare system, I don't know, maybe rural India, is that the file, the medical record, was kept by the patient, because it would go to the doctor and get the diagnosis, pay, and then he would take, or she would take that information, because who knew what doctor next they would see. So they kept their information. We don't quite do it this way. But you do need to follow, and I have some patients really committed in terms of, you don't have to, whatever works for you, but take charge, take some ownership. And then this is a tougher one, and this is one I have to admit I usually dodge the first couple rounds of meeting a patient, but what is the prognosis? And it's interesting how people will not rush to ask that question, but and partly for us, it's not such an easy question to answer. My best example when I was training, so I trained at the Dana-Farber Cancer Institute. It's a fairly popular place. Actually, when I trained there, it was named after the pathologist Sidney Farber. So I trained at the Sidney Farber Cancer Institute. You may want to know what happened to Sidney's first name. And it's because the Charles Dana family donated a lot of money. So, and I think Sidney Farber was no longer around, so he couldn't object, so it became the Dana-Farber Cancer Institute. Fortunately, no one's donated so much money that he lost his last name. But, so it's a pretty cool place. So I was a fellow, and I'm doing rounds. It was late in the day, and I run into someone, and it was a relative, and she said, 89 days. I said, 89 days. Well, my significant other, whatever, had 90 days to live. So it's like 89 days, like tomorrow. It's my mother, actually. Will happen tomorrow. And I was not the author of the 90-day prognosis, but I sat back and said, shucks. I think people don't appreciate how literally some people will take information. The other case I was, again, late in the day, and one of my fellows had seen a patient with breast cancer and newly diagnosed breast cancer, and I walked in to by myself with my white coat, looking like a doctor, and she was on the phone, and she would not get off the phone. So it's like 8 o'clock at night, like as if I had nothing else to do. But I was sufficiently wise to say, it's not about me, it's about her. So I went back, gave her a few more minutes. When I returned, she was off the phone, and she was angry. She was angry because one of my fellows had said she only had a few months to live. And we had subsequently a great relationship for the next 3+ years. So there's some reluctance to throw out information, but at some point it's worthwhile to get a ballpark figure. I mean, everybody's on their own journey, there are exceptions to the rule, but it's a good idea just for your own planning. It's not an easy question to ask. Next slide. This is, I think, another important part, which is in medicine, multidisciplinary treatment is very common. In breast cancer, you have 3 doctors, your surgeon, your radiation oncologist, your medical oncologist. In the background, the radiologist and pathologist play an important role. So a lot of diseases requires more than one doctor. So you should know who your medical team is. It's important to identify who's taking care of you. Nearly as important, you should identify your support team. If you're going through this battle, whatever disease, it is not to be done alone. The saddest situation I find is when I have a patient who comes in to talk about treatments and she's by herself. There's no other ears to hear the story. It's, I think, a bit too much. So that usually means multiple meetings to give her a chance to figure out. I mentioned ownership of the treatment plan. And then get ready for the ride. It is a roller coaster. There are times when things are looking good and things are not looking good. There are feelings you go through, disbelief, anger, fighting, acceptance. These are, the Kubler-Ross sort of levels. All of us go through some process. At the end of the day, and to be honest with you, as a physician taking care of patients with metastatic breast cancer, patients that I know that the disease will catch up with them sometime, sometimes it's years, not always, but I have to go through a little bit of that process myself because, I'm going to ride the wave with them, knowing at some point it's going to crash, but as long as the wave runs for a while, we run together. Next slide. So the team, and the supporting team. Next slide. So the team, I think, you have to be comfortable with people that you think have the knowledge to take care of you. If you're not sure they can take care of you in terms of their knowledge, then you need to think else. Again, the skills, make sure that they're capable. I think probably one of the most important things today in medicine is communication. You know, to get in medicine, when I was applying, you had to be good in science. Whether you could communicate, strike a conversation, teach, as long as you knew calculus and biology and chemistry, you're going to become a good doctor. Well, that's not true. I think actually people who are really good scientists should do science, maybe. But you need to communicate. Maybe we need more people from the humanities who can talk, who can, and more importantly, listen. So communication is used, and there's also a collaboration. I think if you have doctors, so I have patients who say, you know, I'd like to get a second opinion. My job is to say, get that second opinion. Let me help you out to do that. So that's important. So collaboration is important, and then clearly compassion. It's a fine line, but you need to travel that journey with your patient, and you need to feel that your doctors are traveling with you. So get your docs in order, okay? And it's something that's going to be a little bit of work, but you have to. Don't think it's just going to happen. You need to put it together. And ideally, I work in breast cancer with a bunch of docs that we work together. We've worked together over years. Believe it or not, you know, there are different team members, and you know, I've worked with some docs at Sibley and some docs at other hospitals, some docs at Fairfax, but we've worked together. And we actually go to meetings, and we're often at the same meeting, so we've identified. You need to find out who's really taking care of you. And I have to tell you, that's become a greater challenge today than ever before. You need a team captain and maybe more than one captain. I have to tell you, one of the things I struggle with, and I'm just waiting till when I get in the hospital or my wife gets in the hospital, the doctors today are changing nearly every day, it seems. Even the specialists, that team, we rotate now every two or 3 days. This phenomena of the hospitalist, which was a foreign concept, the idea that there's a doctor who only works in the hospital, who only sees patients who are hospitalized, has really dramatically changed how we get taken care of. You know, your doctor, most doctors now, primary care doctors, don't come into the hospital anymore. They don't see you. It's partly practical, but it's the way it is now. And then your specialist rotates. So it's like who's on first. And one of the concerns I have is, you know, I hope this new system and people are just passing the ball always. No one really owns the plan. No one owns that patient. No one is worrying about that patient after they see them. No one's making sure that it all gets done. And so, you know, I mean, you can get around it. You know, I get around it, and other physicians have different ways of getting around it. Some people give their cell phones. I give my emails. Some patients get the cell phone depending on the gravity of their situation. But, you know, a good example, I have a patient who just developed a problem with her breast cancer, and fortunately, her family had access, so that even though we're at a different hospital, they were able to get me involved so I could do my work and communicate with others. And I think it's important to find someone who, as you've taken ownership, they have also, they're the doctor, and it's clear that they're the captain. Next slide. The other thing we talked about a little bit is relationships. I mentioned the paternalistic relationship. The autonomous is the guy who thinks they know all the answers, and the doctor is just on the side. It's not really a good idea. You may know a lot, but you really do need to find someone you trust. There was an article written in the New England Journal by a gastroenterologist who developed gastrointestinal disease, esophageal cancers, Engelfinger, and he was editor of the New England Journal decades ago, and he wrote an article. The essence was, when you're sick, even if you're a doctor, find a doctor. And I think it's true. So, because you do want someone who not only knows what they're talking about, not only knows options, but also will give you an opinion what they think really should be done. There's a good book, if you'd like to read it. It's called Your Medical Mind. It's written by two physicians, Groupman and Hartzman, both from Boston. And it's written for all of us. It's written for when we get sick, how do you go through the decision-making process? And what's really helpful for me when I read it was provide patients options. Not just say, Mr. Smith, this is the way we treat this, but Mr. Smith, this is the way we can treat it, but there are other ways. And by the way, I think this is the way I would go about it, but there are other options. And you find some people choose different paths. Next slide. So your support team, your chief advocate is often a spouse or significant other. We talked about when you visit your physician, it's nice to have that person with you, family, friends. Other support groups, it could be, support groups through a hospital, or it could be your church, whatever. But it is important. And, we grew up, Betty Ford, made it public when she had breast cancer. Before that, cancer was a dirty word. It's not something you talked about. But now people, maybe we talk about too much, but now, it's something families know about. It's interesting when I talk to people asking, what did your grandfather die of? I don't know, they died, because we didn't talk about those things. Now people are a little bit better. Next slide. Treatment options, I'm getting close to the end, I think. So benefits, when doctors talk to you, you might, it depends on the individual how much you drill down, but you may say, this is the cancer model, but how long will the treatment work, or will it make the cancer go away completely? So those are questions, and then short-term, long-term effects. It's very important to understand, are we doing this to improve my quality of life? Are you trying to prolong my life? Have those kind of discussions. Next slide. So if you start doing this, and I hear about how it's very painful for your physicians now that you go and see them, that's okay, because it's all about you. I have a patient I saw today, wonderful guy. He has breast cancer, it's pretty uncommon, and he sends me his list of the agenda before I meet with him. And he has also a great advocate, his wife. And between the two of them, I know I'm going nowhere for a little while, so I get a comfortable chair, and I first listen, and then go through his list with him. But it's how he fights his illness, and there's a certain needs he has to have addressed. So clinical trials, that's how we make things better. What's good about them is they're hopeful because they're new, maybe better. There are all kinds of different types. I don't want to go too much into this, but phase 1 is we're trying to figure out how to give the drug. It's good, but limited. Then phase 2 and phase 3 are really looking at therapy. But it's worthwhile to say, if you can't make this all go away, is there a clinical trial? Maybe that will give me a better chance. And that sometimes does occur with dramatic outcomes. Next slide. Second opinion, frankly, in my world, it's not something you need to do often, but it's certainly something to consider when you're told, boy, I haven't seen this disease ever. So, well, okay, thank you for your candor. Do you know anyone who has? And if you run into stuff, things are just not going as well, and probably your physician is just as frustrated as you are, but sometimes worthwhile. I saw this wonderful 85-year-old lawyer. He has anemia, a certain kind of anemia, and he's had some bone marrows, and we got, I think, a handle on it. But he's so friggin' frustrated that his anemia is not getting better. I've been his doctor for about 4 or 5 years. And he said, we've done multiple bone marrows, and we've gone through a lot of things. I reviewed his case with one of my colleagues, and he said, my family says I think I should get another opinion. And I said, that's a great idea, and then I said, we'll do another bone marrow first, though. But he's just frustrated. He's not getting better, although he's still got pretty good quality of life. Treatment options vary, and then if you're not sure about your team, if you just, it's good maybe to look around. Next slide. Now this is really the nitty-gritty, okay? So the patient who comes in with the agenda that he emails me before I see him, he's not going to fit in the typical 15-minute follow-up visit, okay? It's going to take more than 50. So if I don't budget my time, and I don't know this is coming, the next patient might be a little upset waiting another 15 minutes before she's seen or he is seen. So plan your meetings. A list idea is fine. The most initial appointments are only an hour. You should know that. It's okay. We don't charge by the minute yet. Most appointments are only 15 minutes. So the frustration I sometimes feel is someone has an expectation I'm going to spend a half an hour with them, and no, I'm not, because I have another patient. But if I know you want a half an hour, then I can plan it. So part of it is, and I have patients that say, I need half an hour. It's okay, we'll put that half hour in there. Checklists, it's amazing how smart people can be, but when they get in the office, they kind of forget the things, and they're driving home, and they turn to their spouse and say, "Forgot to ask that question." And I actually, I don't say I get a charge out of it, but I like it when someone says, "Here's my list." Well, that's great. Let's go over it together, so we can knock it off. You get it? And then there are, different aspects. Medical costs, I won't get into that too much, except it's important, and it's not necessarily intuitive what's being paid for today. And I'm not talking about the people with the lousy insurance policies that someone said that you could keep, but you can't. I'm talking about regular good policies, but there are co-pays, and we actually have all our patients who are going to be treated see what we call the patient benefit specialists, and they go over the patient's insurance, so they know what they're going to be responsible for, so they're not surprised. Nutrition, sex is important to talk about. Travel, what can I do? I have a lot of patients, amazing, can travel, but if you don't ask, is this genetic? That comes up. Complementary care, is acupuncture, is Reiki, is certain nutrition. And most physicians, I think, are pretty open-minded. Most of us don't know much about it, though. I mean, people come in with supplements to say, well, the supplement industry is not regulated. Like, it's not. I mean, you may think that you're taking this, but it's not clear you are. So that's number one. Number two is the research is poor. Not non-existent, but poor, partly because no one's going to make a lot of money, i.e. pharma's not interested. And the trials that you hear that have these blockbuster results are costing millions and millions of dollars. So if you think carrot juice is the answer, no one's going to fund a large carrot juice study. There is some stuff, there are certain things. Retinoic acid was supposed to be good for lung cancer. There was a large trial that looked at that. It's not good. It actually made it worse. So what you're going to get, the pushback you may get from your physician is, one, I don't know much about it. I don't know if it works. I don't know if it's safe. But, it's unlikely it will be unsafe, but if you do it in moderation. The last piece is kind of important. It's not a topic we like to talk about, but it's essential you do, which is advanced directives. And all of us should have them. Our spouses should know, or significant others should know what our intentions are. It is, and the spin on this one is, if you don't talk about it, someone else will decide. Who best should decide but you? Who knows your wishes better than you? And I had a patient I took care of, and her husband, and we talked about it, we got it down. She had a crisis, went to the emergency room. What do emergency room docs do? Save lives. Metastatic cancer, end of life, save lives. That's what they save lives. So she got intubated. The next day I rounded. We didn't get called. I saw her husband, and we looked at each other, and we said, this is not what she wanted. And she got extubated and then was able to die. Not quite as peaceful as we thought, but these are things that if you don't talk about. And I have to tell my own personal story. My mother died at the age of 90, about a year or two before she died. I have 3 siblings. We got on a conference call because we, of course, don't live in the same city or the same country anymore. And the first conversation I have a sibling who's a doctor and 2 non-doctors. The first conversation I had is, I don't want to talk about it. But I started my conversation early. I knew I was going to have many more conversations about it. So finally, when we got to the point where my mother was close to the end of her life, we all were on the same page. So she died peacefully. But if you don't have these conversations, and if you have children, that you make sure that your children know about it. We occasionally have someone, I've been taking care of the patient for years, patient's near the end of life, it's all been worked out, and some child, adult, comes out of nowhere about, I don't want to stop. First of all, it's not your choice, but it's important to talk about it. Next slide. So this is a slide. We're getting near the end. I know there's some wine being served. A living will. Last night, my husband and I were sitting in the living room, and I said to him, I never want to live in a vegetative state, dependent on some machine and fluids from a bottle. If that ever happens, just pull the plug. So she's sitting there in front of the computer. That's the machine, I think, and the bottle is, I think, something she's drinking. Anyway, so she made it clear, right? So he got up, unplugged the computer, and threw out her wine. Next slide. So they'll finish up. The roller coaster ride is, when initially you have a disease, a lot of good things can happen, at least initially, and you should hear about them. You shouldn't get completely despondent. But then as things progress, the traits change. And probably the best example is if someone gets admitted to the ICU and they're kind of sick, but not that sick, and you come to the patient or the family and say, you know, there's a chance to get out of here, do okay. And then the second day, they're now intubated, so they're on a respirator. Chances are not so good anymore. The third day, the nephrologists come over because it's time to consider dialysis. As someone deteriorates, the expectations change, and one of the challenges for everyone is to change expectations as the status of that patient changes. So that's as you go through a process, you know, there's a point to fight. There's that, you know, that song, there's a time to hold them, there's a time to fold them. There's a time to fight, and there's sometimes a time to say enough. And what I find with my patients, these are patients with metastatic disease. We know at the end it's going to catch up with them, although they can live for years, talking about breast cancer. But every time we change treatment, we say, okay, we're in a fork of the road. As Yogi Berra said, take it. But you know, you take one of the forks. And we have it. I mean, is it time? Are we? How are we doing? Now, amazingly, I'm a little bit biased. Metastatic breast cancer patients can look really good for a really long time. So they have great performance status, even though they got metastatic disease. So we find if there's a fault is sometimes we treat beyond maybe we should because we get fooled. But anyway, that's a discussion. And you know, I don't want the story I told you at the beginning where you have to tell your doctor enough. Hopefully your doctor's with you on that. Next slide. The other thing we have to worry about, and I'm talking about physicians and maybe relatives, it's called the white knight syndrome. This is from Alice in Wonderland, I think. And we fall prey to this. We want to be the white knight, not the black knight. We want to come in and save the day. We want to make things better. We really want to be the good guy. And sometimes we struggle to say, you know, maybe we need to be more of a black knight. Usually try to get one of our partners to do that. And then there's hope versus truth, and this is a little tricky. If you're overly hopeful and not truthful, it turns out it's a disservice. But you can still be hopeful and truthful. And there, you know, and people, you never can lose hope that you can do things that will help the patient have a better quality of life. And what's learned, and this is kind of an interesting, there's a study, there are many studies, but this one from Korea, where the culture in Korea is you don't give up, at least if you're from South Korea. But it turns out that people do better with truth than not truth. You sometimes have cultures where don't tell the patient they have cancer. Well, first of all, if you're going to treat them, it's kind of hard to do that. But secondly, most people get it. If you don't, they already know it. And then this is tricky, not to, as difficult as it might be, you need to be honest in terms of the hope. Next slide. This is a little bit, now we're getting a little bit in a pessimistic mode here, but this is reality. There's a time where, you know, all of my cards have been used up? Is it time to think about palliative care, hospice? And the only thing, the takeaway is don't let other people try to manage this last phase of your life. I mean, you know, if people may not know. I mean, I was at a meeting where this insurance person was saying, you know, we spend so much money in the last 30 days of someone's life, the last 90 days of someone's life. And my response was, we're not born with a termination date on our forehead. You know, I don't know when people are going to go sometimes. I mean, but as things begin not to look so good, it's good to have that conversation. I'm beginning to terminate here myself. Next slide. So the last conclusion is, it ain't over till it's over, Yogi Berra. A little bit graphic there, but that was it, I think. And the last part is say thank you very much, and if there are questions. You've been very patient.
Anybody have any that they want to
Yep.
ask? Yeah, Dave.
So I have two questions. One is, compare the Canadian situation with American, if you can. You're from Canada.
Yeah.
You know, you always hear these horror stories about the Canadians. We don't want to be in the Canadians.
Yeah, you might have insurance.
We might have, right. We might have insurance. We might actually have insurance.
Yeah.
And then the second thing is, talk about why you guys don't know about nutrition. I mean, what are the med schools, you're out of med school, obviously, but what are
Fortunately.
My son's into that and talks about the fact that most of the doctors just don't know about it. And you said that.
We're pretty limited. So let's go back to Canada. I live here, so that's a bit of a statement. But it's one reason my wife is from Ohio, and I'm originally from Quebec, and elle parle pas beaucoup de français, so it's a bit of a problem. It's a French-speaking province. So one thing I'm nice about Canada when I visit is everybody has insurance. We're all covered. You're all covered. You lose your job, you're still covered. You move from one company to another. Matter of fact, you could make it a case that it's great to start a business there, because the last thing you have to worry about is insurance for your employees, because they're already covered. What's the challenge, though, is access and the waiting list to see specialists. It's a fee for service. We don't, it's not so much bundle care. But for example, oncologists, most oncologists work for the government. They're non-private practice. So there isn't that free market. You could argue we have too many oncologists. The other thing is we probably have more MRIs in the city of Washington, or the greater area, than probably all of Canada. We have lots of toys, tools that are out there, and people ask for them. And the expectations, the little culture difference. I talked to one of my colleagues, and her aunt of 90 was getting a knee replacement. So it's not like Canadians give up on old people. It's if it's appropriate, it gets done. It may take a while to get it done, though. So the good news is you're covered. Not so good news, if it's not an acute problem, it can take a while to get that care covered. So that's frustrating. And that has led, there is now a little bit more of, it's not that private practice ever went away, but there are now some more options if you want to go along the private sector. So I think it's, and of course, when you measure the metrics, the United States doesn't do well, Canada does better, European countries do better. And that could be because there's more access to care and people don't wait till the 11th hour to come in for their illness. In terms of nutrition, we hear about it. I think it's, there's a huge issue in terms of nutrition misunderstanding this country if you look at the amount of obesity. This country has literally become quite fat. And that's because a lot of people don't understand nutrition. You could argue it's somewhat related to poverty and what foods you can buy for a few bucks. The trouble is when you begin to drill down, it's even the vitamin story. If you look at studies taking vitamins, it's hard to make a case that we need to, if you eat well, do you really need to take vitamins? So I think...
I don't call that nutrition.
Okay. Yeah, I think there's a limited amount of what, you could probably go over with someone their diet. We do talk about nutrition when I see patients that I'm treating for cancer, but it's not eating the obvious that we shouldn't eat, and eating, less meat, more fish, more fruits, vegetables. But after that, the trouble is how much of it is evidence-based. You hear that term a lot, and it is not. After that, it gets a little bit cloudy. And there are people who make a business about giving advice. As it should be, but after you get, I think, through the first round, I don't know how much more there is. One of my friends, one of my classmates had a book, a breast cancer book, and had a bunch of recipes, and frankly, it's pretty much testimonial stuff. So I think you run into two things. One is, I don't know, nutrition is important, but how important it is once you get beyond the elements, what would consider good food. And two is how much is evidence-based, and we, right or wrong, a lot of what we try to do is evidence-based. When I tell someone they need to take chemotherapy, yes, these are poisons. We're trying to kill cells, and we're trying to make sure you survive the experience. I have to have evidence. I can't just come in and say, I think this is a great idea. Now, you might argue, you might say, Nick, yeah, that's not a fair example because we're talking about nutrition, food, and you're talking about giving someone some poisons. You better have pretty good evidence that the poisons are going to help. So that's sort of where it's at. But I think it's a fair criticism, and maybe spending more time. the other problem is there's obesity, and postmenopausal breast cancer is related. If you're fat and you're postmenopausal, body mass index of 30 plus, that's getting up there, and I don't see anyone guilty of that in this room. There's a relationship with breast cancer. The next trial is a trial to then convince someone who weighs much more than they should to begin to lose weight. But now the data is pretty firm, so that's part of our job. But trying to be successful is another story. So I don't know if that answered all your questions.
John?
Yeah, there was, I'm sorry.
Yeah, back to your example in the emergency room. Was there some way to be better prepared, if you have a advanced directive or for yourself or your spouse, and for some reason the ambulance comes and they go into full gear and try to save a life that they shouldn't be saving?
Yeah.
How can you persuade them not to?
Well,
flash all the things in front of them.
yeah, well, so when I have patients undergo hospice, we tell them never call 911. Because if they're near the end of life, and I actually, it's never happened before. I was in my office on a Saturday. We're open Saturday and Sunday for a couple hours, and I had a patient die in the office. And it was not clear what his advanced directives were. Not clear what was happening to him either. But then, so he collapsed. We called 911, but then he woke up for a moment, and enough to say, I don't want anything done. So the 911 team came over, and they were, it's like a SWAT team. They're coming to do action, right? And I had to say, it's okay. He doesn't want anything done. And they said, are you sure? Are you sure? And I said, I'm his doctor, covering actually for one of my colleagues, but I said, he doesn't want anything done. And they just had to be, so part of it, I think you're right, if you, so that was pretty extreme. Someone at hospice near the end of their life. Let's say you're sick, but you're sick enough but you don't think you're at the end of your life, and you go to the emergency room and they do all kinds of stuff. They're supposed to go through, but it's a very difficult time. I mean, what are my chances of really getting out of this? It's a bit tricky. And if it's something that's reversible, how reversible is it? So it's a complicated discussion. I mean, if you have if you're near the end of your life, you have a fatal disease or whatever, and you've had a catastrophe, a medical catastrophe, and everybody's going to be nervous. No one's going to try to pretend to figure out this at home, even if they're skilled. So they go to emergency room, but it's developing some limits. But I think we've been talking about when you go alone to the emergency room, it's a bad situation because you don't have an advocate. So it's good to have an advocate with you. If you have documentation of your wishes, that's also key. I mean, that's important. So, yes, sir. Yeah.
I'm concerned about this disconnect between your internist, the guy that knows and has treated you for 20 years, and then you're dealing with a hospital team. Now, how do you get a captain to that team?
Yeah.
And how does your internist participate?
So I'm working hard on this because I figure I'm going to be a patient someday, or my wife, and I've already informed my wife that her doctor won't be in the hospital. So this is a big problem. And it's made worse that the hospitalists, the new guy or gal, doctor, that you see is going to disappear in 2 or 3 days, and you're going to get another one. And the consultants are doing the same thing to you. So when one of my patients gets sick, now one of my colleagues or I are rounding in the hospital, and we can now access data more easily. But I don't think there's an easy solution. One solution is for your physician of record, if it's understood that he or she is still playing a role in your care, they need to communicate probably on a daily basis. If they can't round to see you, they need to maybe talk to you, or it's a challenge. I don't think there's an easy solution.
In choosing your physician of record, should you ask that question?
Yeah. I think it's we've had to educate our patients that when you get sick in the middle of the night, we're not going to be in the emergency room. When I joined this practice over 20 years ago, the expectation would be, I had patients at 2 a.m. say, you'll be there in the emergency room. And I said, no, I will not be, because I'm going to be working all day and I don't know when you're going to come in. So there'll be a physician who sees you who then will call me and will review things. But I think it's important you establish and understand what your physician will do And he or she may say, well, I won't be there, but I'll be available. And then when I'm in the hospital, will you stay involved? And see what that answer is. Because if they're basically going to hand off to a new team, it puts a lot more pressure on you and your family to help you get through this. But this is, you're in an area that you're not familiar with, so it's pretty difficult.
Well, what are hospitals doing about it then?
Well, the hospitals are trying to get patients in and out, and they're trying to make sure they don't bounce back in 30 days. Because the way this financial structure is, you get penalties. So they're being stimulated to figure out. So if you have a doctor, the way the hospitals will do it is they are communicating electronically or by phone with your doctor. And the question is, how good is a handoff? And how much do they know? Now, fortunately, as more and more facilities have electronic medical records, you can access them. I can access the hospital. I can access my medical records. And I can do both of these at home, theoretically. But I think it is worthwhile to have that kind of discussion. And if you're going to have it, you might want to give your physician a heads up that, this is something. So what happens when I get sick? Who takes care? It's like when you pick a physician, you should know what hospital they use. I mean, if it's a hospital you don't want to go to, maybe you need to rethink the physician, with all respect. So, but these are conversations that are very good to have. The patient I told you, a young woman who's developed something, is now admitted to another hospital in the area. I mean, her husband knew how to get in touch with us. We got that information. We were able to call him back, and then we were able to call physicians involved in her care, all done in pretty much real time. But it's a to and fro, give and take. You have to have someone someone's going to do all that for you. But I think it's very frustrating. I don't have. It used to be great that your doctor would come in, and even though they weren't the expert, you knew them and they knew you. But it's frustrating. It's frustrating. So there's a patient who Nancy knows about. Nancy's my wife, because I talked to her a few times. She was a really wonderful, wonderful lady who just died recently, and fought her illness for a number of years and went through a number of clinical trials. Single, had a career and was still working at the beginning of this, but had a great support staff, support team, and so much so that her family. Her sister, who lived in another state, said, why don't you come and live with me at the end of your life? And she said, no, I really would like to stay. First of all, I didn't want to change doctors. That was part of it. But the other part was her support. So every time she would come in, I would see like a different person who would bring her in. So she was very deliberate. Hospice got involved, but her friends and family, her family came up, to be supportive as well. And what was amazing was she fought her illness really hard, underwent different clinical trials to improve her outcome. But we together got to a point where more treatment was not best. And I was really, I hope I do as well. She was able to turn on a dime from fighting her illness with vigor to going through the last part of her life with vigor. And the reality is when we stopped treatment, she felt a little better for a while. So not a surprise. But she, I never sensed, she put trust in the people taking care of her, but she was involved. And we just, it was, she was just a great example of someone who was able to do it. So it was partly, I think, being honest with herself and her situation and confronting, what things would appear to be unpleasant, but realizing that it was better to confront it and to take charge. So, I come in and do a consult, and it's relevant, issue. And what I have done is given my card with my email and my cell phone, because I see this happening, and it often doesn't get used. But when it's just things are not necessarily falling through the cracks. It's just the story is muddled, and they can call up and say, you saw me a couple days ago. I need an update. I think someone on the medical team has got to say, Mrs. Smith is my patient, and I'm going to worry about it. But it's a different world. The hospitalists, it's not quite, and with all respect to them, it's a difficult job, but it's like a shift job. They work their shift, and they do a few shifts, and then they move on. And they're good and they're talented, and when they're in front of you, they're engaged. And and how to sign off. It was hard. It's hard enough for our group to sign off. There are 9 of us, but anyway. Okay.